desktop. All right. Morning, everyone. Um, so today we'll continue on with digestion. That's our plan. Hopefully you saw I uploaded the video on Blackboard. I think I put it under lessons, right? I uploaded it, right? Yeah. I'm not losing my mind, hopefully. I put a folder there. I don't know if it will update you as I add them to Blackboard. So heads up on that because I have to wait for like WebEx to process it and then wait for YouTube to process it. So at some point I do upload it. I think if you subscribe to the YouTube channel, that will alert you when it's processed. So heads up on that because I put it to process and I walk away from my computer when I can leave my computer open. So heads up on that. We're gonna speed it up a little today, so just be mindful of that to try and keep us on track. Monday there is no class; we are short a class is our issue there, and then Wednesday we'll continue on. Starting next week, attendance you must attend to get those up to 5 points on each exam. So either you're logged in or you're here in person, so that I can verify your attendance for participation points. Okay, so be mindful of that. All right, let's share the PowerPoint. Make it full screen. And where's my chat? There we go. Okay, so I believe this is about where we left off. Digestive anatomy. So, when we talk about the cavities in the body in general, we see there is what is called peritoneum. Peritoneum is like a film, like a covering. Think like saran wrap. So there is a saran wrap that is tight around the organs, and then a secondary layer that's usually attached to like outer wall. So when we talk about like in the abdomen, around the organs, attached to the organs is visceral. Viscera is organs. So that's the visceral peritoneum. And then on the outside, like touching the underside of the muscle, if you will, okay, like skin side. Away from there would be parietal peritoneum. Peritoneum refers to the abdominal region. So we'll see these terms used as we move through different compartments of the body. So be mindful of them. Throat's getting dry. Between the two, there's serous fluid, just like in the joints, like in the synovial joints. And what this is going to allow, like as we move and the organs move, or as food is going through them, it allows them to move without friction, without wear on the tissue. Okay. It also, like if you look at it like as an infection side of things, it compartmentalizes the different areas. So like say you rupture your colon, that infection doesn't migrate into like your CNS immediately. It takes time for it to spread through the body. It slows things down, gives us more of a fighting chance. So visceral peritoneum, like I mentioned, that's attached to the organs, and then parietal peritoneum attached to abdominal wall or outer wall. So we'll see when we look at heart, for example, there is visceral pericardium and then parietal pericardium. When we look at the lungs, plural, okay, or pleura, sorry, that's for lungs. Parietal is that outer, and then visceral pleura attached to the lungs directly. So the way this is can be kind of confusing to students. When you look at this, think of it as a sack. And then let's use this. Let's see if we can do it with this. If I take my fist and I push into here, there is a portion of this wrapped against my fist. If this side bends down and was to continue all the way down, my fingers are wrapped in there. And if this continued down, this would be parietal. The inside center that's touching my hand would be the visceral layer. Okay? So what happens is when this was forming, this sac was wide open down the middle. And the organs formed in there. And then it basically vacuum sealed onto it. It suctioned to it. So you'll notice the very bottom here, it's sealed. And then as we climb up, we see these little connections, and then another organ, and then a connection, another organ. This is all internal in here. This is going to be referred to as intraperitoneal, anything that's surrounded by the peritoneum. We'll see a big old fold here that we'll talk about. And then we'll see another organ in here. We'll see a connection here. We talk about that connection. And we see another organ in here. And then the final connection. And then it parts and goes this way and parts and goes this way and finishes the seal as the parietal layer. So intraperitoneal refers to any of those organs that are wedged inside the sac. They are covered on both sides by visceral peritoneum. So they mentioned the stomach, the liver, portions of the large intestine, and small intestine, because it winds through. During embryology, when it was forming, it wound through. And actually, the wild thing is your intestines were actually outside of your body during embryology. Your intestines actually come out as one loop, and then it starts to twist and then gets suctioned back in, and then your skin grows around it. There are errors in that time. So my brother-in-law is a colorectal surgeon, and during his fellowship, he had where a newborn, it's called omphacele, I believe is the proper name for it. They had a partial omphacele. So the kid was born, their smaller, large intestines were outside of their body, and then it was like sealed around it. So he had to open them up, stuff it back in there, and seal it back up. And they'll survive. There's even some where, or I think that's a full omphacele, a partial omphacele. When the child's born, you see like skin, and through the skin, you can actually see their intestines. The muscles didn't form properly. And so they'll do the same thing. They'll open them up, push it down in, and then suture everything together. Pretty wild. And like have to put it inside the peritoneum, all of that. So it's a random embryological defect. It's not anything anyone did or anything like that. Maybe minus drinking alcohol while pregnant, okay? The first 3 to 8 weeks are organogenesis. That's where like all the formation happens, and that's where it's like super crucial, where teratogens, things that can affect the fetus, are like super high risk. Okay? Retroperitoneal, that means it is outside of the peritoneum, or sometimes they'll say it's covered on one side. So like the kidneys, for example, are retroperitoneal. They are outside of that peritoneum. The front side is touching that visceral layer. Okay. So they mentioned here duodenum, pancreas. Okay. And once again, large intestine, depending on the portion. Here, intraperitoneal, I have a list for you guys, and retroperitoneal. Make sure you guys learn these, go through them. They could ask like a random question, like, is this organ intraperitoneal or retroperitoneal, right? Like, that's fair game. So definitely go through and learn these. And I have a memory tool here. So this is for retroperitoneal organs, pucker. It's a good little memory tool. At least you knock some of them out quickly. Okay, so pancreas, ureters, colon, kidney, esophagus, and rectum. All right. Mesenteries are those sections of the peritoneum where they're fused together between the organs. So like you have organ and then another organ here, the portion that is connecting the two. Okay, so when you guys do cat dissection in lab, it'll really help with these, connecting these, learning them. My throat today, what's going on? Hey, I was near the, you know what? I'm gonna blame it on the niece. I was near my wife's niece this past weekend, and she was sick. We're gonna blame it on her. Falciform ligament, that is what connects liver to diaphragm. It's the highest up. So when you're looking at the cat in lab and you lift up on the diaphragm and you see the liver below it, you'll see a little thin membrane essentially connecting the two. That is that mesentery right there. Lesser omentum, that is stomach, to liver. So once again, if you pull up on the liver and you look, and here's stomach, here's liver, thin little membrane between the two. And then greater omentum is referred to as the apron. That is that big long guy that hangs down and covers all like the small intestines. That one, when you're looking at the cat, you can actually like pull it out because it's completely just hanging over and tucked under. You can actually pull it out and lift it up completely without tearing it or anything like that. And you'll see like fat deposits in it even. So, move this out of the way. There's falciform, diaphragm, liver. There's lesser omentum, liver, stomach. There's greater omentum, or the apron. And that'll actually really tuck all the way down here. Falciform, lesser, greater. So here on the cat, there's diaphragm, there's falciform, there's liver, there's greater omentum, that yellowish big piece. So here, they're showing the general mesenteries between the small intestines. There's that apron, the greater omentum. So make sure you guys go through these. Mesocolon and mesentery proper, that's just these portions here. That's mesentery proper. And then mesocolon is around the large intestine. Okay. All right, moving along. So these 4 layers right here, mucosa, submucosa, muscularis externa, serosa, they are a standard all through the GI tract. As we go through, those 4 will pretty much always be there. The only thing that'll change is the 4th one, serosa. When you're intraperitoneal, serosa. When you're retroperitoneal, adventitia. Okay? That's the only difference there. Now, as we move through each organ section, there's going to be a unique feature, at least one, in one of the layers. That's like kind of the key thing you want to learn, those differences. That's what's unique to like duodenum. That's what's going to be unique to stomach, okay? But these 4, standard. So I always remember in mucosa, he's got 3 subcategories or 3 parts that make him up. No problem. You got it? Yeah, I don't hear myself anymore. I remember elm, like elm tree, okay? So epithelium, lamina propria, muscularis mucosa. The second you hit muscularis mucosa, you move into submucosa. The unique thing in submucosa is vessels. That's where you're going to find arteries and veins. Then we go to muscularis externa. These muscles, longitudinal, the inner circular, outer longitudinal, these are the ones that will do peristalsis and segmentation as needed. They're the ones moving the food bolus through, or eventually feces. Okay? And then lastly, either serosa or adventitia. So, like we said, mucosa, epithelium, lamina propria, muscularis mucosa. Submucosa, it has the enteric nervous system, so the submucosal plexus. That's going to affect like secretions, blood vessels. Muscularis externa, there's that peristalsis, and that's controlled by the myenteric plexus. If you've taken micro, you learned about Chagas disease, the reduvid kissing bug. It actually paralyzes the myenteric plexus. Because of that, they develop megacolon, megaesophagus. It can rupture. Because there's no peristalsis, stuff builds up there and can rupture. And then you'll see it too. I saw it in a case in peds. The child was autistic, And in autism, for some reason, sometimes they can have dysfunction of the myenteric plexus, as well, I believe, in Downs, if I remember correctly. And so you would palpate in the ascending colon here, and you could just feel a mass. And so he would have to get enemas periodically to help clear it so he wouldn't rupture his colon. Okay. And then serosa if we're intraperitoneal, adventitia if we are retroperitoneal. Serosa, it's visceral. Adventitia, it's just more for attachment. It's more like a firmer connective tissue. Um, that's really its whole purpose. Whereas when you look at serosa, because there's friction potentially, so that we have that fluid in there to stop that friction and give it a lubricating fluid. Endocrine. So we talked about that on Monday. That is hormones being released into the bloodstream. It's slow. It's not fast acting. It requires that wherever that hormone wants to act on, that there is a receptor for it. If the receptor is not present, it can't do anything about it. It won't work. Okay. Versus, and it's long acting. Versus nervous system, fast, specific, very, very quick. Fast onset, fast offset, right? I snap my finger, that's it. Quick, done. That's the end of it. Versus if a tiger bursts into the room right now, I'm going to run and I'm not going to stop running, right? I'm going to be sweating. My heart's going to be racing. It's going to take a while to calm down. That's endocrine. Okay. Autonomic, parasympathetic versus sympathetic. What's parasympathetic? Calm. What else? What do we always say when we say parasympathetic? Rest and digest. Is there a lot of activity happening? We're calm. Heart rate is slow. What about our digestive tract? Is it moving? Yeah. Right? So there is stimulation to the digestive tract. It is working. That myenteric plexus is functioning. We have peristalsis. We have segmentation. We are moving the food. Sympathetic? What's sympathetic? Increases the heart rate. Stands for scared, right? So we are fight or flight. Do I want to devote energy? If I'm being chased by the tiger, do I want to devote energy to breaking down food? No. I don't want to stop to pee. I don't want to stop to pass stool. It shuts the system down. Okay? So when we're rest and digest, parasympathetic turns up. We're moving food through. When sympathetic turns up, we slow it down. Okay? We decrease the activity. So the enteric system, that's the gut. That's what we're talking about. There is an effect on motility, so movement. There's effect on secretion. We would be secreting during the parasympathetic time. And then, like I mentioned, the myenteric plexus for movement, submucosal for stimulation of secretions. All right, mouth. So structure of the mouth, you have the labia, which is the lips, teeth, oral cavity, tongue. You'll go through this in lab as well. The tonsils are aggregations of immune cells. And so anywhere there is entry to the body, so we look at like into the mouth, lymphatics, through the skin, or exiting the body, so like in the ileum. We'll notice because there's really no bacteria there. The next stop is large intestine, the ascending, technically the appendix, and then ascending colon. There's bacteria there. We'll see there are white blood cell aggregations there in the ileum. It's kind of like a guard at the entry door. That's their purpose. If bacteria is coming in, they will see it, They will stimulate the immune system and get ready to defend the body. So that's why we see them there. So we used to take tonsils out all the time. I actually had my pharyngeal and palatine tonsils removed as a child. And they did it because I was snoring as a kid. That's not normal, right? Um, so, I stopped now. My wife says I do, but I don't believe her. I never hear it. Right. Okay. And then pharynx. It's really bad when you snore so bad that you wake yourself up. It's a little startling. So these are the pharyngeal. Where did my pointer go? There's the pharyngeal. Sorry, palatine. What am I saying? Pharyngeal are up here. The palatine tonsils, those are the ones like when you open your mouth and look in the back. And then pharyngeal up high here. They also call them adenoids. They scrape them off. They grow back. They actually grow back. The palatines don't. So some patients, the palatine tonsils especially, get infected with strep. And so they'll keep on having, like these kids, keep on having these repeat strep, right? Month after month after month. And so the palatine tonsils are actually colonized by the strep organism. And that's why they just keep on getting the repeat strep throat. All right. As far as the mouth goes, the gums, stratified squamous, it's typically not keratinized. It doesn't have that keratin protein in it. But if you agitate it a lot, so here they say flossing. Nowadays we have like the electric toothbrushes. Invest in one, get the Oral-B. That's my recommendation. And then get a water pick. The one you plug in for flossing, it shoots the water. It's like pressure water on your teeth, through the gaps of your teeth. Really, really prevents cavities. My dad's a dentist. He's one of those people that traumatizes people. And then my youngest sister is a dentist. Over Thanksgiving break, I let her work on my teeth. Mistake numero uno. Oh, man. She's special. Anywho. And then connective tissue, that's lamina propria. Lamina propria is always our connective tissue, which is areolar tissue. Okay. Pharynx, we looked at this the other day. Naso-oro-laryngeo. All right, nasopharynx, only air passes through it. So because only air passes through it, it's pseudostratified ciliated. Okay. Oropharynx and laryngeo, food passes through it. So it's getting abrasion. So it's stratified squamous. Muscle, standard, longitudinal, circular, same as everywhere else. Okay. Esophagus. So there's a real image here, cadaver. That's the esophagus right there. They've cut the trachea away. That is descending aorta. Diaphragm. There's an opening here. That's the esophageal hiatus. There is, like when you guys look at the cat and everything, you won't be able to see the opening because it's occupied by these structures passing through it, and there would be fascia sealing this. We have to have this whole compartment sealed so that when the diaphragm draws down, it creates suction, it pulls on the lungs, we can breathe in. Okay? So when you look at it in lab, students always like freak out. They're like, I can't find the hiatus. It's a hole there. You can't see it unless we would remove that tissue so you could see the hole. You just know it's in that area. Length of esophagus depends on the person. Their height, the height of the thorax, it's going to be different. Upper esophageal sphincter, that would be at the top. Lower esophageal sphincter, right where we meet stomach. And then hiatus. Carbs. My favorite. All right, we're going to debunk some stuff. Okay? It doesn't matter what you eat. Carbs, protein, fat. Your body turns it into glucose. Has the ability. Okay? It does not matter. Carbs are not bad. We've been sold this like diet, you know, no, that carbs are bad for you. They're not bad for you. Okay. You're supposed to eat all types of food, all three categories. Moderation is what's important, right? Um, the problem with carbs is like if I eat a piece of candy or I eat pasta, they both are glucose. But when we talk about chemical digestion and absorption, in order to absorb, it must be in the monosaccharide form or the monomer, the individual. So that's glucose, for example. That's one of them for me to absorb it. If I eat a piece of candy, it's already in that glucose form, or it's just a disaccharide. Versus if I eat a piece of pasta, that is a very long carb that I need to break down before I can absorb it. Okay. So the ability to pull the energy in, get the spike in energy, use the energy spike, and then end up going, well, there's too much, I'm going to store it. I convert it into fat and store it as fat. That's the problem with simple carbs. Complex carbs take longer to break down, less spike, especially when you talk about like in diabetics. That's why diabetics, like they always recommend oh my gosh, what's the brown rice, the brown pasta? Why am I blanking on it? Not the no, not gluten. What's the brown pasta called? Whole wheat. Yes, yes. There we go. Thank you. That whole wheat structure takes longer to break down, but if you look at like the calories and everything, they're basically identical. Actually, the whole wheat can sometimes have more calories because you have more of the structure of that plant. So, because it takes longer for them to break it down, there is less spike in A1C, less spike or glucose, I should say, not A1C per se. That spike in glucose, and we'll talk about it when we talk about diabetes, when there is high glucose amounts, it penetrates into the cells more readily. And that's what's causing the damage because once it's in the cells, water follows, and that's what damages the structure. So by having them convert over to that, eat less carbs, more protein, we kind of control the spikes. Your body cannot survive without glucose. And that's why I'm telling you, fat and protein can be converted into glucose. Um, the the brain must have direct glucose. Okay, so our body can convert amino acids, certain amino acids, not all. We'll look at those, and any fat into glucose. Okay, the when we eat, that's the mechanical digestion. We're chewing it, and then our stomach churning it. Okay, mashing it. The segmentation is technically mechanical digestion, but the chemical, I said mechanical, right? Mechanical digestion. The chemical digestion is the enzymes, the acid. That is what's breaking it down to the monomers, the simple sugar, amino acids, monoglycerides. Okay, so we can absorb it. It can be pulled into the bloodstream. We need water to do this, and we need enzymes. So hydrolysis, hydrolysis. Lysis is rupture, break, hydro, water. There's water everywhere in our body, right? They list, here. And then just in general, you'll see like goblet cells all throughout the GI tract. They're releasing mucus. Mucus is watery in itself or a water source. And we looked at this the other day, what enzymes are. You guys, you got that. I'm not worried about that. Okay, so carb digestion. When you eat a piece of bread, it is a polysaccharide. You start to break it down in your mouth, but it's minimal. There's amylase in your saliva. As it's coming down your esophagus, you're still breaking it down, but it's minimal. And the problem is when you hit the stomach, what's in the stomach? Acid. What is that going to do to the enzyme? What are enzymes made from? Proteins. What happens to a protein when you hit it with acid or an enzyme? Denatures. If I lose the nature, I lose the form, I lose the function. The amylase will no longer work. Okay? So it's minimal. Once we make it out of the stomach into the duodenum, we have tons of bicarb there. We have tons of mucus. We neutralize the acid, and the pancreas dumps in amylase. That's really where we start to break down the carb. Okay? And then we fine tune it in the jejunum. We'll see there's what's called brush border enzymes. In the jejunum, you have villi, and then on there, they're like little hairs. They're microvilli. The microvilli between them are the brush border enzymes. Brush border, like it's like a hairbrush, is what they're trying to like say it looks like. You'll see stuck in there your lactase, sucrase, maltase to break down lactose, sucrose, maltose. Right? So, I think we got everything on there. So here we see duodenum. There's the pancreas, pancreatic duct, and releasing the amylase to start breaking it down. Brush border enzymes in the jejunum, finish it off, break it down to the monosaccharide. We must have monosaccharides. They refer to the brush border enzymes also as disaccharidases because they're breaking down disaccharides. If you speak another language, sugar is what? How do you say sugar in a different language? Sukar, al-sukar. And in Arabic, it's sukar, right? Sugar, mono, one, di, two, poly, technically three or more. Okay? That's all that's saying. So it's one sugar, two sugars, or three or more. So what happens if you don't have lactase? I think that pen wasn't, or marker wasn't too well. Let's say we're in your jejunum. You don't have the brush border enzymes to break down a disaccharide. You can't absorb it. If you can't get to the monosaccharide, you can't absorb it. Can't pull it in. So it keeps on going on its merry way. Well, the problem is it's solute. And you guys didn't cover this in AMP1, did you? Hypotonic, isotonic? Did you guys cover that? Okay. This is a hypertonic solution. What's going to follow it? Salt. Well, it is like the salt. So what follows it? Water. Water migrates out of you into the lumen of your gut. And then what happens? You're lactose intolerant. What do you get? Diarrhea. This is the same concept if you look at like all your sugar-free drinks, candies. That's all it is. They're the synthetic sugars that are so bad for you. They're not bad for you, okay? They are just the sugar that you lack the enzyme for. So what happens if you consume too much of them? You will get diarrhea. The gummies, the gummy bears, the sugar-free gummy bears. Oh, if you look those up, the reviews are hilarious, and I can testify to it. My wife and I decided to do keto one time. Like, we'll try it out. We're bored, and I have a bad sweet tooth, and I ate the whole bag of those things. I lived in the bathroom for about 3 hours. It's horrendous. Okay, do not eat large amounts of those. All right. So here, what they're showing is here's like glucose or galactose. There we go. These are monosaccharides. They've been broken all the way down. In order to pull them in, the transporter here, this is a transmembrane protein. The transporter here has to move the monosaccharide in along with sodium. We need the sodium to operate this co-transporter. A co-transporter means two things are moved. They can be moved antiporter or symporter means two things are moved. Co-transporter means two things are moved in the same direction. Antiporter means two things moved in opposite directions. And we'll talk about that again when we get to like kidney and stuff. So once it's pulled into the epithelial cell, it then can migrate into the bloodstream. So this is why when you look at like drinks like Gatorade, for example, certain Gatorades, I don't know about you guys, but like the yellow Gatorade, I can taste the salt in it. Like if it's warm, ugh, it's disgusting. But it has to be in there so that like when an athlete is drinking Gatorade, what happens? They can absorb it more rapidly. They need that sodium in there. One, they're losing sodium through sweat, but also so they can pull the glucose in and they can use the glucose to make ATP, replenish themselves. Okay? And you shouldn't be drinking Gatorade unless you are sweating profusely, basically. That's the only time you really should be drinking Gatorade. It's excessive, it's not necessary. So, carbs, we start to break down in the mouth, but then we really start to break it down in the duodenum and finalize it using the brush border enzymes in the jejunum. And we are using water as well as the enzymes to break it down. So my advice for learning these as we go through each food type, one, you need to know polysaccharide, disaccharide, monosaccharide, know where it's broken down at and who's breaking it down. Okay? So you could do like a flashcard on the front, carb, and then have the questions. What's like his multiple levels of size? Where is it broken down at? What is breaking it down? Okay? And that's how you learn these. Proteins. Yeah. Oh, they have a chart in there? Okay, yeah. Use the chart. They already did the study, made the study material for you. Don't reinvent the wheel. Use the chart then. What is it? 19, page 19? Okay. Yeah, awesome. How are we doing on time? Ah, we're good. Oh, it's at 12:50, right? Proteins. Proteins are made from amino acids. There are only 20 amino acids out there. They refer to, depending on the textbook you look at, I think ours is the 11 and 9. 11 are non-essential, 9 are essential. What that means is the 11 non-essentials you can actually generate in your own body from other products that you've eaten. The 9 essentials you must get through your diet. Where do we get protein? What's protein? A steak, beans. Okay, you can get plant protein or you can get animal protein. It's one and the same. That's another like gimmick you're sold. Oh, this protein is so much better than another. Okay, yeah, it depends on the book. Some books say 10 and 10. It's like semantics, right? But yeah, it's protein is protein. Your body looks at it as amino acids. It's kind of like it is the alphabet. The amino acids are the alphabet, and they can generate every word. So these 20 amino acids can generate every protein depending on how you combine them. It's one and the same. All right. Amino acids, or sorry, proteins, their digestion begins in the stomach. The acid in the stomach begins to break down the protein. And that's why I think we talked about it on Monday, like when you make ceviche. How do you break down the bacteria protein structures? You put like lime on it. That acid in the lime is sufficient to start destroying it. Okay? So it kind of creates a dilemma. Why is our stomach basically not eating itself? The acid not consuming it. There is also an enzyme in there that we release, and then activate, and it does not consume us. So we have a protection by the mucus layer. That's really the biggest factor. Okay, and these notes for some reason say, but what the rabbit hole we're about to go down. But in reality, it's the mucus layer. If the mucus layer is disrupted, that's coating your stomach, you develop ulcers. So this is why certain patients, when they're on like certain medications, we must give them things like Nexium or omeprazole, esomeprazole. Nexium is esomeprazole. We must give it to them to prevent like stress ulcers. So under stressful conditions or burn patients, they will just suddenly develop ulcers. You have a patient in the ICU, they will put them on Protonix or Nexium or Omeprazole to protect them. That stressful situation on the body is sufficient to disrupt the mucus layer and they start to damage themselves. Now, that's to protect us from the acid. But here we're talking about an enzyme that breaks down proteins. Well, we're generating it within the stomach lining. There is a catch there that this would consume us. This would eat our stomach material. So we create what's called a zymogen. A zymogen is like a precursor. It is not active, or they refer to it as a proenzyme. So the zymogen here is pepsinogen. It's non-active. When it's secreted out into the stomach itself, the hydrochloric acid, the HCl, that activates it. And it becomes pepsin. Pepsin now can break down proteins. It is safe now because we got it out of the body. Okay? So students trip out with this. Don't freak out. Don't freak out. Don't do it. In the pancreas, same thing. We cannot release an active enzyme. It would consume us. So what do? We create zymogens. So we release the zymogen trypsinogen. There is a brush border enzyme called enterokinase. He's our activator. He's our HCl in this situation. He turns trypsinogen into trypsin, and it's a two-check process. I don't know. Do you guys have to do the two-check process for like your email and stuff now and to sign into your like Blackboard? It's the same thing. That thing drives me nuts. I'll be logging on my phone and then it's like, could you confirm that this is you? Bro, I'm on my phone. You're sending it to my phone, right? Anywho, so it's a two-step check. So trypsinogen is secreted out. Trypsinogen gets activated by the brush border enzyme enterokinase and becomes trypsin. We lose the gen. Okay? Now that activates the two true enzymes that have been secreted. Chymotrypsinogen and procarboxypeptidase. So trypsin is our activator here and turns them into chymotrypsin carboxypeptidase. Those are the two active enzymes that will break down the proteins. So in reality, we release these three from the pancreas: trypsinogen, chymotrypsinogen, procarboxypeptidase. None of them are active. When trypsinogen encounters enterokinase, activates them into trypsin. Trypsin in turn activates the other two into chymotrypsin and carboxypeptidase. They are now active to work on proteins. Okay? When patients have an obstruction here, so like gallstones, this will lead to pancreatitis because these enzymes will eventually, some of them will activate, or lipase activates, that's being released in here also. It is active and it starts to break down the pancreas and that leads to that pancreatitis. All right, the jejunum. So that's where we see the breakdown of the dipeptidases. That's two amino acids together and using brush border enzymes, dipeptidases, or sorry, I said dipeptides are broken down using dipeptidases and aminopeptidases. So same as when we were looking at the carbs, the disaccharides. And same thing for absorption. We need salt. We need sodium. To pull it in, it's a co-transporter, and then we can absorb it. So I think that's part of the reason of like primal, if you look at it, why we have such a want for salt. Like food doesn't taste good if there's no salt on it. You can season it all you want with other stuff. If you put zero salt, it don't taste right. Okay. So salt is important in our diets, especially iodinized salt. So I don't know if you guys ever noticed that, like when you're buying salt at the store, there's iodinized and then just regular salt. Get the iodinized. You need it to prevent goiter, which is enlargement of your thyroid. You'll have hypothyroidism if you do not have it. So as far as proteins, we start breakdown in stomach. We work on it from the enzymes that are released from the pancreas and the duodenum, and then we finalize the dipeptides using dipeptidases and aminopeptidases in the jejunum. Then we can absorb. Once it is into those mono amino acids, that's it. We can absorb it. So what do we do with this? We turn it into either ATP, we store it as fat, or those amino acids, that steak I ate, I break it down into the individual amino acids, I absorb it, I build my own tissue, right? I build my own protein structures. So same thing with when we look at fat, all of these, you're building your own structure. So you truly are what you eat. I'm a whole lot of like hamburgers. All right, triglycerides. So triglycerides, they have that glycerol head, 3-carbon structure, and 3 fatty acid tails. We break it down into a monoglyceride and 2 fatty acids. We use water and we use lipase. Lipase is our enzyme here to break down fat. Where does the lipase come from? Duodenum. So where's the first point that we break down fats? Duodenum. He is late in the game. Breaking down fats takes time. Okay? So we use bile. We need a soap to break down the fat. We're taking like big globules of fat and we're going to break it down through emulsification using the bile to break it down into small pieces. We do that so now lipase has more contact points. That's the entire purpose. Bile is not an enzyme. Okay? It's made up from these different bile salts, these different components. It's really a soap when it comes down to it. Emulsification just means to break down the fat into smaller pieces. And the whole purpose is to give lipase more contact points. And we're breaking down into a monoglyceride and 2 fatty acid tails so we can absorb it. So here they're showing that emulsification. So we had the big fat globule, smaller ones now due to bile. Now lipase has more contact points to work on it. It makes it more efficient. So emulsification is kind of like that pre-treatment. It's kind of like, it's the same logic to if you get a stain on your shirt, an oil stain. What do? You spray it with something like Shout before you put it in your washer. So the pre-treatment, emulsification, bile, that's the Shout. You're breaking it down into smaller pieces. Then when it goes in the wash and you have that soap in there, that's the enzyme and it works on the last little bit. Breaks it down even more. Soap is fat, which is pretty wild. When you look at what a fat structure is, it is a polar head and a non-polar tail. That's exactly what soap is. So what happens when you have fat sitting here, the non-polar tails will line up around it. And then when you go to wash it with water, the water is polar and it can rinse it off your body. You guys know what soap used to be made from back in the day? Animal blubber. That's why they used to hunt whales back in the day. That's where it came from. It's kind of weird, like you bathed with fat. Food for thought, right? So once we get it to these monoglycerols or monoglycerides and these short and long fatty chains, we can absorb it. Okay. Oh, they mention also the myceles. So the myceles are the bile with lecithin. So these are like where we've combined the lipase with it, and that's the myceles. The myceles are the very tiny structures. You probably heard this term before. what is it, like Neutrogena or someone that has the micellar wash? I don't know if you guys ever seen that, the myceles. That's what they're referencing, that it breaks down the oils on your face into small structures that can be washed off. Now, does fat dissolve in water? No. What is your blood made up from? Water. We have a problem here. Okay? We can't just dump it into our bloodstream. So, what do? We combine it with a protein. We wrap it in the protein to shield it so there's no hydrophobic reaction. Now it's hydrophilic. This protein is a hydrophilic protein. It can move through the water, shuttling the fat. That's chylomicrons. That's your LDL, HDLs. That's what they're talking about. Low density lipoprotein, high density lipoprotein. And the other unique thing here is we still don't go into the bloodstream. We go into the lacteals. The lacteals are the tiniest guys of the lymphatics. You absorb it into the lacteals, then it transports it as chylomicrons into the bloodstream, and then it carries on through the body. Okay? So because of this is why you must be fasting when you do blood work. If you're not fasting when you do blood work, that fat will enter into your bloodstream. When they draw blood on it, your HDL and LDL will all be wonky. One time I drew blood on a lady, and she was a dementia patient. A battle to get to allow me to do a blood draw. It was in a facility, like a home, and so we were like the house doctors there. And finally, I had to bribe her with a Diet Dr. Pepper to allow me to draw blood on her. I draw blood on her. I didn't even get a chance to spin the tube down. And I'm holding the tube, and you just see like that much white in there. It's fat. It's all those chylomicrons floating around in it. So I went to the nurse or MA or whatever that works that area, and I was like, what did they eat for lunch? Like, fried chicken. It's like, oh, okay. Right? Pretty wild. You can see it. Okay? So here they're showing breaking it all the way down. There's those myceles, and then entering into the lacteals in the microvilli of the intestines. So here's a chart showing the effect of lipids, how it's breaking it down into the different structures. For us, we really talk about it in the duodenum. We talk about the bile is breaking it down into smaller structures, the lipase breaking it down into smaller structures, and there's those myceles. And that's where, you're talking about the same exact thing as like soap around fat. We looked at this. I don't know why it doubles up, and I keep on forgetting to delete it. I think someone previously was using it as a review. There we go. We're here. Okay, we're still good on time. So, esophagus. Kind of jumps around. Mucosa, submucosa, muscularis externa, adventitia, because it is technically retroperitoneal. It's outside the peritoneum. As far as mucosa goes, we see the epithelial will change as we transition through the different parts of the GI tract. So here, it's just carrying food and passing it through. So it's going to get abrasion. So we should see stratified squamous. Okay? Lamina propria is lamina propria. Nothing special there. Muscularis mucosa, it's muscularis mucosa. That's always the same. There's nothing unique there. Submucosa, nothing special there. They should add in that there's blood vessels, but nothing special. Muscularis externa, there's something unique here. The upper 1/3, voluntary. We control it. So, skeletal. The second 1/3, you don't really have control over it. It's mixed. It's transitioning. So we see skeletal plus smooth, or striated plus smooth. Lower one third, no control anymore. Pure smooth muscle, inner circular, outer longitudinal. So really the unique things here, epithelial, stratified squamous. Muscularis externa, the different portions where it goes from voluntary to involuntary. And then adventitia, right? The rest is standard, not changing. So here, there's the mucosa. There's our lamina propria up in there. It's very hard to see. It's very like thin. Submucosa. See, there's a big old vein. Whenever you're looking at submucosa, you'll always see arteries and veins. That's a vein. That's probably an artery right there, just for reference. Okay. Then we move to the muscularis mucosa. There's the inner circular, outer longitudinal, and then adventitia going around there on the outer layer and thinning out right there. Okay. Peristalsis, we talked about this. Myenteric plexus is controlling it. Parasympathetic through vagus stimulation is controlling it. And it's just moving food through using the muscularis externa. So, is there any digestion of food in the esophagus? Any digestion of food in the esophagus? I've got a few shaking heads no. And we gotta know at home. What happened in the mouth with carbs? Anything? What enzyme? What's the enzyme they're secreting though? Amylase. Salivary amylase. So as it's passing through the esophagus, there is a little bit of chemical digestion that's happening. Only on who? Carb, fat, or protein? Carbs. Okay? There is a slight amount of digestion happening. But remember, once we hit the acid in the stomach, it's not going to do anything anymore. And once we get to duodenum, pancreatic amylase, that's the big player. GERD, gastroesophageal reflux disease. This is due to laxity of the lower esophageal sphincter. I actually have this, so I take Nexium daily. It's the only thing that's going to work. The reason I have to do this is because of that LES laxity, acid comes up into your esophagus. Your esophagus is not designed to deal with it. If I leave it exposed, what will happen, that repeat exposure, you develop what's called Barrett's esophagus. Barrett's esophagus is the transition over to cancer. It's headed that way. And then eventually you develop proximal adenocarcinoma of the esophagus. So what do? We take Nexium daily, okay? And we avoid certain foods, right? Every patient's a little different on what's going to trigger their heartburn. And I have learned margaritas are not a go for me. Me and margaritas do not mix, even on Nexium. It used to be no spaghetti, control the amount of caffeine, spicy food. But now, like, I've got my dose dialed in and we can avoid margaritas. All right. Um, so yeah, the only other treatment is surgical. They go in there and they basically tighten up that LES, but the problem is it tends to be too tight afterwards and you have trouble swallowing food. I can take a pill every day. We'll live. All right. Diaphragmatic hernia. A lot of times you see this, they're born with it, and a portion of stomach is moving up the into the diaphragm, and usually it's on this side over here, the left side of the abdomen. The diaphragm is defective. There is a hole, and so portion of the stomach moves into there. There's compression of the lung, so they have difficulty like breathing. They can't take big deep breaths, stuff like that. It can choke off a piece of the stomach. It can become necrotic, and it's a medical emergency at that point. It's a pretty easy fix. They do it laparoscopically now. They just go in. They use like the Da Vinci machine. I don't know if you've ever seen that. The surgeon sits like behind a screen, behind a wall, and he's operating a computer basically, and it's got surgical arms and it does the surgery. The reason they do that, it augments for the surgeon's movement, like if they shake or something, and it gets rid of that and it does like a precise movement. So it's pretty neat. Pretty neat tool. And it's kind of crazy. They were saying the newer age surgeon, so my brother-in-law uses it, for example, that someone like him is better at it than the old school surgeons. Like old school surgeon, they're great, whatever, and they went to Da Vinci machine, they're not good at it. And they said the reason is the younger group played video games. So because of video games, the eye-hand coordination was way better. Their ability to like move, slight movements, stuff like that. And I thought that was pretty neat. Okay. So, easy. They go in there, they just suture the diaphragm closed, put a mesh if they need to. Problem solved. Hiatal hernias, once again, you can be born with. This is where a portion of the stomach is coming through the diaphragm hiatus, that opening that's already existent. And a lot of times you see it in like alcoholics and bulimics because they vomit so much, they strain so much that it pushes it up into there. So that's a common like population you'll see it in. And then they also can actually rip the esophagus from straining, and they can rip the stomach wall. They'll come in profusely bleeding, and when they vomit, it's like this black vomit. They call it not melena. It's coffee ground emesis. It looks like coffee grounds that are wet because the acid is oxidizing the blood, the hemoglobin. Once again, surgically fix, not a big deal. Stomach. So, stomach, a couple different areas you need to look at. Cardia, because under the diaphragm, it's sitting right there, and heart is sitting like this. So that's why they reference it as cardia. Fundus is the peak, body, the body. Greater curvature is this long curvature, lesser curvature, the smaller. And then we have the pyloric sphincter here, which closes it off from duodenum. Unique feature with the stomach is muscularis externa. So we have longitudinal layer, which is the most superficial layer, circular layer, that was our inner circular, but now we just call it circular layer, and then oblique layer. That is the most deep layer. That is closest to the lumen of the stomach. So we add in another muscle layer, and that's just really to help with churning the food. So here, mucosa, submucosa, muscularis, serosa, because we're intraperitoneal. Mucosa, the epithelium changes. We have what are called gastric pits and gastric glands. Gastric pits, when we look at the stomach, we have what are called rugae. Rugae are these big old folds, and that allows the stomach to expand. That's really its purpose. On the surface of the rugae, on the epithelium here, there's indentations. These are the gastric pits. Okay, so really these would be kind of like open, kind of like little cups on the surface of the tissue for the secretions that come out of here to sit right there. If we don't have the gastric pits, as your cells secrete the different things that they secrete that we're going to talk about, like the acid, for example, it would just fall down into the little grooves. The mucus would fall down into the little grooves. Instead, we keep it uniform over the surface. That's the purpose of gastric pits. And the gastric glands, those are the individual cells we'll talk about that create the different secretions. Okay? Lamina propria, same. Muscularis mucosa, same. Some mucosa, nothing to note there. We should have blood vessels, nothing special. Muscularis externa, inner oblique, middle circular, outer longitudinal. So we added in that inner oblique layer, and then serosa because we are intraperitoneal. All right, so here's the fun cells that we work through in the mucosa. First up, goblet cells. Pretty much every simple columnar cell has the ability to produce mucus. If it produces mucus, it is a goblet cell. When you guys are in lab and you look at this and you see that mucus vacuole, that clear area inside that goblet cell, that's a mucus vacuole. That is a moment in time that you caught it and you saw it. The cell next to him that doesn't have that mucus vacuole in it is also probably a goblet cell. He can produce the mucus. You just moment in time. Maybe you already just secreted it. Okay. We need that mucus to protect against the acid. If the mucus is gone, the acid will eat the stomach lining. It will destroy it. Parietal cells, they're pink. This is one of the few times we'll tell you, like when you're looking at them in lab, if you see a pink cell in the stomach, it's a parietal cell. You can learn the color. He will secrete hydrogen and chloride separately. The two will combine inside the stomach and form HCl. Has a pH of about 1 to 2. It is a defense mechanism. It protects us from bacterial infections. So, proton pump inhibitors. You may have heard this term, PPI. PPIs are Nexium, Protonix. Notice the name Protonix, protons. Or proton. Yeah, proton pump inhibitor. And omeprazole, they're stopping the parietal cell. They're actually stopping the portion, the transmembrane protein that pumps in the hydrogen. By doing so, only really chloride's going in. Some hydrogen goes through, depending on the dose you're taking. And so you make way less HCl. Way less HCl, less acid in the stomach, less heartburn. Very effective drug. Okay. Downside to that is if you have less acid, you have less immunity. The acid kills bacteria. That is technically part of our immune system. That is a chemical defense system. So I'm notorious for getting like food poisoning. My wife and I will eat the same exact thing. She'll be fine. Everyone else around me eats the same thing. I get food poisoning. Okay. I'm just lacking the sufficient amount of acid to kill the standard amount of bacteria that's on our food. All our food always has bacteria on it. Doesn't matter what you do. Okay. We use it to activate that pepsinogen into pepsin and for protein breakdown. Intrinsic factor. So the parietal cell function is necessary to produce intrinsic factor. Intrinsic factor binds B12. It must be bound to B12 so you can absorb B12. So in people that are vegans, because they do not eat animal protein, people that have had their stomach stapled or a stomach bypass, or they have pernicious anemia. Pernicious anemia is a destruction of the portion of the parietal cell that produces intrinsic factor. It's an autoimmune disease. They must take injections of B12. Everyone else does not need B12. Vegans don't even need injections. They just need to take a pill of B12. No one else needs B12. If you eat a standard diet, you don't need B12. That's another like gimmick a lot of people try to sell. Well, you're deficient on B12. Okay, pull up the lab work and see if you're deficient on B12. You probably aren't. Okay? So yeah, stomach plays a role. What do we need B12 for? Anyone know? No? Any guesses? To make red blood cells. If you are lacking B12, you'll develop what's called a macrocytic anemia. Your red blood cells won't form properly. They'll actually be giant and not very functional. So when they tell you you're B12 deficient, ask for them to look at your red blood cells and see if you have a macrocytic anemia or not. If you don't need B12. Okay. Chief cells. These guys will be blue and bluish purple, deep purple, pretty standard. Okay, they secrete pepsinogen. Pepsinogen is activated by HCl into pepsin to break down proteins. Enteroendocrine, entero, gut endocrine cells. These are going to secrete into the bloodstream. So first up we look at is gastrin. Gastrin releases releases into the by the G cell or the endocrine cell, is released in and stimulates the stomach. So we release this when we eat. And what it's stimulating is the parietal cell to produce HCl to break down the incoming food. So when we eat, gastrin, more HCl, more breakdown of food, specifically protein. Enterochromaffin cells, these release serotonin. So whenever you get nausea, it's not really because of your stomach. Your stomach is encountering something that it says should not be in your body. And so it releases, the enterochromaffin cells release serotonin. Serotonin goes to the brain, and the brain starts sending down the signal that you feel nauseous. And even starts the reverse peristalsis so you can vomit. So what's the medication we give for nausea? Anyone know? What is it? On Zofran. Okay. Zofran is a 5-HT inhibitor. 5-HT is serotonin. So it works here. Wonder drug. It's good stuff. They prescribe it a lot of time pregnancy. When women are vomiting, during morning sickness profusely, because they're going to alter the pH of their body, stuff like that, right? If you lose the acid, you're going to keep making it, lose it, making it, lose it. You'll alter the pH of the body. Patients on pain meds, they'll prescribe it along with the pain med because they can cause nausea, and then just general. Someone having issues with nausea, you're going to go on a cruise. They can write you some Zofran. Okay. And then chromaffin-like cells, so these release histamine. Histamine stimulates parietal cell to release HCl. So the old school heartburn medicines, they're antihistamine drugs. So if you have heartburn and in a pinch, you don't have Tums, whatever, you could take like Claritin, Zyrtec. Those are antihistamine drugs. Okay. Benadryl. Old school. So here they're showing of the stomach. You can see the gastric pits. Here's the cells lining it. Usually the parietal cells, are higher up because they're making acid, and the chief cells are typically lower because they're making pepsinogen. So it's a little safer for them to release it lower. Same image. And this is a close-up showing the chief cells, and they're releasing pepsinogen, and then the acid in the stomach converts it to pepsin. The enteroendocrine cells, or the G cells, will be lower because we need to be closer to submucosa because that's where the blood vessels are, and they're endocrine cells, so they need to release into there. Muscularis externa, like we mentioned, 3 layers, interoblique, circular, longitudinal. So when we eat and that food bolus comes down, we need to churn it. We're mixing it. What we're mixing it with is acid. We're mixing it with the pepsinogen, really pepsin at that point. And it's going to activate. We're churning it up, we're breaking it up, and we form what's called chyme. Chyme is that mixture. Now it's ready to go into small intestine. What's stopping it is the pyloric sphincter. Okay? The pyloric sphincter is stopping it from entering. We churn it, it pressurizes, and then we open the pyloric sphincter a little bit, and a little bit comes in. We take a little bit at a time so we don't overwhelm the enzymes. So some people, it's typically babies, newborns, they will vomit, projectile vomit, and it's just milk. It's all that comes out. And like mothers will freak out, they'll bring the kid in. And what's happening is they typically have pyloric stenosis. Baby's tiny. The opening for the pyloric sphincter is tiny. Okay. So usually they'll let them go for a period of time and it'll correct itself as they grow. If it doesn't, they go in there, they just balloon it open a little bit. Like if the baby's having failure to thrive, like nothing's getting through, that's a problem. Something will be lacking in their vomit. If you or I vomit, you keep on vomiting, what happens? You vomit up what? What color is it? Yeah, if you have a bad vomiting session, after you get all the food out, everything you drank, all the Jaeger, what do you vomit up? Color is it? Never vomited like that before? Never been deathly sick? Ugh, you need to eat more foreign food. You're missing out. What happens if you vomit? It could be clear, and then after clear, it's going to be something else. Clear means stomach is empty, and it's pretty much mucus and acid. Green. Green or yellow? Why is it green or yellow? What's coming out? What does that green or yellow signify? Bile. That's bile. You have evacuated so much that even now out of your small intestine, duodenum, stuff is coming up. So in these babies with the pyloric sphincter being closed off, when they projectile vomit, you don't see bile. That's always a sign that it's the pyloric sphincter. They also say you'll feel like a little olive bump on the baby. On the outside, you can feel it because everything's so thin. They don't really have fat yet, stuff like that. Remember, bile is going to inject through with the pancreas through the common bile duct into duodenum. So if you close off here, no bile coming out, no bile coming out of the body. HCl, like we mentioned, you produce a decent amount, 2 to 3 liters a day, but activating pepsinogen, killing bacteria, and breaking down protein structures and helping form that chyme. All right, I think that's a good stopping point because we got 2 minutes left. Any questions for me? Feeling good? Did we fill out our lecture notes? Fill out your lecture notes. Don't be chasing the whole semester. Okay? Don't chase the whole semester. The analogy is this. If you've ever heard of someone when they have like surgery or something, they always tell them take the pain meds before you feel the pain. Because once you start chasing the pain, you're never going to catch it. It's the same thing with the material. Don't chase the material. You'll never catch it throughout the semester. Okay? Get ahead. Fill out your lecture notes. Finish digestion by Wednesday. That's where you want to be at. Finish digestion in your lecture notes by Wednesday. All right? Cool, cool, cool. Enjoy your weekend. I will see you guys Wednesday. Email me if you need me. Bye.